Welcome to the Pulse of Healthcare. This is Dr. John McCormick. I'm here with Peter, and we're going to do kind of a multi-part series. So we're just going to tackle a few of these things at a time, and I really want to talk about some of the reasons that healthcare is more expensive in America than the rest of the world, really, right? I mean, it's crazy, isn't it, Peter?
That's what I've noticed is that the United States healthcare is so much more expensive. I, and yes, there's technology involved, but why is it in the United States that we're paying all these escalated prices based upon activity and performance?
Well, and I guess if we had to do a cost benefit analysis, if we're saying, well, we're paying more, we should have a better outcome, right?
Right.
But we don't. We actually are paying more, and the life expectancy in America is actually lower than most of the developed world. So there's obviously a disconnect in what we're doing dollar wise and what the outcome is health wise. You know? And so we want to talk a little bit about that and some of the reasons that, you know, some of the published articles that are out there that kind of explore, at least peripherally, why people think people that are doing analysis think that this might be the case.
Well, it's what last time I went to the doctor, he came in for took a like pulse and a cup blood pressure, and then he was gone. I mean, it was yes, he wrote me prescriptions. Yes, he referred me to another doctor, but I didn't see him for more than 2 minutes.
Right.
I felt like I was a bump in the road as he was running down.
Well, and part of what you said is interesting on two fronts. One, the way we incentivize our medical professionals is counterintuitive. We are not incentivizing them on outcomes. We are incentivizing them on activity. How much or how many people do I see, not how well is my patient. All right?
Yep.
The best performing hospitals in the country, with the best outcomes are actually the ones that have physicians and specialists that are on staff and get zero incentive based on, activity. There's all their incentives is based on outcome. Did my patient get well?
Yep.
Was the surgery a success? All right. And by doing that, they actually reduce the overall cost of care within the facility, and some of them even share back those profits with the physicians.
That's surprising. I have not run into that. I've run into being referred to a specialist and then going through that same activity of having him come in, take a look, and he's moved on and referred me to somebody. He's got that same number of patients or performance payment as the other doctor, so I'm getting an abbreviated stop-by medical care on multiple levels.
Right. Well, in December in the USA Today magazine, they put out an article about 7 things. We're not going to talk about all 7. I just want to talk about a couple a day. We might add on to this in future podcasts. But some of the key points that were brought up in that article were that we spend more on administrative cost than we do for caring for heart disease or cancer. All right. So I want to peel that apart a little bit, because when we think administrative costs, people immediately go, well, that's the insurance company. Well, it's not. All right. Although administrative burden is certainly a component of health insurance, there's also administration at the doctor's office. There's administration at the hospital. When we talk about hospital CEOs with salaries in the $10 to $20 million range, that's part of the administrative cost of your care. So how many supervisors are walking around in these large hospital systems? How many supervisors are walking around in a large multi-specialty practice? And then, of course, insurance carriers as well, right?
Right.
How many layers of bureaucracy is one of the major carriers paying for that is taking dollars away from actually the delivery of care? And we already know it's in the tens of billions of dollars, right?
Right. you go into the doctor's office and there's the receptionist, there's people in the back, there's people taking tests, there's the doctor, there's a whole team, and most of them are administrative when you really get into the office.
Right. And a lot of that is due to overregulation. I honestly think it's overregulation. I mean, 25,000 CPT codes that you've got to put in the right order, and if you don't do it in the right way, then, and every carrier is different. So where this combination of codes might work for Cigna, it doesn't work for Blue Cross, and it's different for Medicare, and it's different from Medicaid. So even at the, at the hospital level, when they're billing for the same procedure, they might have to configure that bill 20 different ways to get paid from the different carriers. So there's a lack of standardization and overregulation that certainly dives directly into this, what I would consider to be really an unnecessary medical administrative burden.
It delays the medical care. It certainly basically tells people, because they know what it's going to cost, or they know they're going to get referred to other people. Unless it's absolutely necessary medical care, it's a lot of work to go through.
It really is. I mean, we're not telling any secrets if we say, the cost of medical insurance, aka then medical care subsequently, all right, has really jumped 3 times faster than wages in the past 24 years. So you got to think, since the implementation of the ACA, when everybody said, oh, it's going to go down by $2,500, really it's gone up by $5,000, in some cases $7,000 a year just for your base level care, right? A lot of that was the administrative burden that came along with the new regulations and the mandate of plans having to include coverage or care that wasn't necessary.
Yeah.
I mean, one of the big ones that's always out there is, well, we have to provide, care for women for birth, right? Well, now that's included for women that can't even give birth, and men, and plans that wouldn't even include them, and so it's like, so now we're saying you have this mandatory thing that's embedded in a plan that's not even specific to the population you might be serving, but yet you've created an administrative burden inside that plan to manage that reporting. So I've said this in previous things, medical bankruptcy is one of the leading causes of bankruptcy for Americans, generally.
Absolutely.
It's in the top 3, right? And then more than half of consumer debts in 2022 were all medical bankruptcy. Think about that. More than half.
Well,
all right?
I certainly, having gone through some large medical procedures within the family, and getting the bills and the surprise bills and the difficulty even in looking and auditing a bill, that doesn't surprise me in the least.
Yeah, not at all. So here's some good news. Just came out today, the official announcement today. So we'll see how it plays out in court, because God forbid we do something that helps people, all right, without having some third party interests want to fight about it. The Biden administration finally passed their law that says that medical debt cannot be reported on your credit report. All right, so they're going to take that out. Now, a lot of companies were already voluntarily doing this because this has been coming for a few years, but now it's official and it's actually effective as of January 1. That medical debt should not be on your credit report, period. All right. The upside of that is that's going to help this population, right?
Right.
That could increase their credit score by 20 points in some cases. All right. That's the difference between a high interest loan and a medium loan. That's the ability for consumers to get better credit ratings, to be able to enjoy lower rates, and be able to improve their overall circumstance.
We'll see if it comes down.
Well, it's down. I mean, of course, the credit collection companies are throwing a fit and saying, well, then people won't pay their bills. That may also be true. All right. I'm not saying that's not true if there's not reflected on their credit report. However, there's all these subtext layers that are built into this medical credit reporting that people are just not aware of. Right. So I'm going to bounce back just a minute. So we talked about you went to the hospital, you got surprise bills,
Yep.
right? And I said, depending on the combination of codes and the carrier, that bill might not be paid by the insurance company the first time around or even the second time around. So it's very complex. I hate to say by design, but I think in some cases that it is by design to make it hard. So to make it burdensome to the facility, to the provider, which I think is unfortunate. Right. All right. So what happens? So the facility sends the bill. The carrier rejects it because it wasn't in the format they want. And instead of fixing the bill, they turn around and bill you. Right? And if you're not a savvy consumer and you don't know, hey, if I get a hospital bill, the first thing I should do is never pay it, right? Never pay the first bill, all right? And investigate it, find out, has my insurance company paid it? I went through this personally just a few months ago. All right, I went to the doctor. 2 days later, I got a bill. You owe, it wasn't much, like a couple $100. You owe $200. I wrote back, I do not owe $200. You need to bill my insurance carrier, which isn't me, by the way. All right. And a week later, I got a letter saying you owe $200. I wrote on the letter, I do not owe $200. There's no evidence that you have submitted this claim to my insurance carrier to get paid. I paid my copay. That's the end of my responsibility. Mailed it back. 2 weeks later, got another letter. You owe $200. Then I said, I'm not going to say how much. I bill this much an hour to resolve medical problems, all right? You can pay me to resolve your billing problem, or you can actually bill my insurance carrier and collect your money. That was the last communication, but you know what? They did finally bill my carrier, and I got an EOB. But it only took me doing that 3 times in 2 months in aggravation, and that was for a small bill, all right? Hospitals where you might have a $10, $20, $30, $40, $50,000 bill, and they didn't bill the carrier, they didn't bill the carrier in a timely fashion, whatever reason, right?
Right.
And then they go, well, we'll just pivot that over to the member, and the member is now responsible. Well, if the member doesn't know to push back on that and say, hey, wait a minute, I'm not the sole guy on this deal. You should be billing the insurance company, and then I have to pay my portion, if I have one, right, based on my carriers and the coverage, right? Do I have a deductible? Do I have coinsurance? Well, those are totally my responsibility. But if I don't, then you're talking to the wrong guy. Right. You need to be talking to that insurance company and not me, right? So first of all, don't panic, right? Push back, ask for that itemized bill if you need to. So there's lots of different ways to go about pushing back on those kind of things, but you got to know to do it.
That's quite a challenge. We get all these bills at home. We get the power bill, we get the mortgage bill, and they're just automatic pays. So now we get these hospital bills and the inclination.
And those letters are scary.
They are.
We're going to. You need to. And there are some states where hospitals would go directly to the courts and get wage garnishment and all kinds of things to pay these egregious bills that were way outside the bounds of what any of the carriers would have paid for the same service at the same hospital. Now, fortunately, a lot of that has stopped over the last few years. All right. Hopefully this new Consumer Protection Act, where they're not putting it on your credit, is going to help facilitate even more cooperation between the service providers and the carriers, to do that and take the member out of that equation. Because, certainly somebody that's having a medical crisis doesn't need to be in the middle of a financial crisis at the same time,
Right.
you know?
And that's what happens.
It is exactly what happens, right? So we know that, this is that we live in an economy that's, about profit. That's capitalism is a great thing. It's part of what makes America great. But there also should be some balance, right? When you have health insurance companies making 25, 30 billion dollars in profits, hospitals making 90 billion dollars in profits, in the course of the year, maybe our focus is a little bit off here. Maybe we should be delivering care where people can afford it and not be, feeding the Wall Street so much.
Right.
I'm not going to pretend I have a solve for that. I just think that there's a balance between nationally run healthcare, and I've been all over the world as a military person. I've seen good examples and bad examples. I mean, I've seen people that have been delayed care in the countries where they have universal health care for 6 months, 8 months, a year. Somebody that could have had a minor surgery and walked out had they had access like we do here in the United States, ends up with a double amputation. Just saw a story about that last week. Minor knee surgery would have been in and out here in a week in the U.S. In Canada, ended up waiting 6 months to get the surgery. All right. And then another 3 or 4 weeks to complete it. And it caused an infection. A lady ended up losing her leg. All right. So there's some definite upsides and downsides to the way we do it. Upside is we have in America much greater access faster in most states.
Yeah.
All right. Some states, not so much. But in most states, we have much. All right. But we also, as a result of that, pay more. Right. And in some cases, we're really not getting that focused, what I'm going to say, core level care. You described it when you first came in. I saw my primary care for 2 minutes and he referred me to a specialist.
Right.
But had your primary care spent 20 minutes with you, you might not have ever had to go see a specialist. Had he actually said, I can slow down my revenue cycle of having to see the next person to make sure I get paid, all right, to make sure that I give Peter all the care that he needs so he's not having to pay me and pay some specialist, and pay some imaging center. Really, if I just would have spent 20 minutes talking to him, I probably could have determined what the root cause of whatever your problem was,
right,
and been able to solve that for you. And maybe it wasn't a medication solve. And so that's another thing. We're conditioned, and we in America take more medication than anybody in the world. We take, 6 to 10 prescriptions. Most, countries, one, and in some cases, none. All right, Asian countries, 1 prescription, maybe. European countries, 2.
That's interesting.
We take 6. All right, we take prescriptions for everything. When really the answer is diet, exercise, get out in the sun, walk a little bit, don't eat so much junk food. If we take care of our bodies will take care of us, and we don't have to have all these prescriptions, because sometimes there are prescriptions, when you take those, you're taking prescriptions to counteract the bad effects of another prescription. So
that's why I when I would look with my father, I saw he was taking 7 prescriptions because he had gone to different doctors and gotten a different prescription written, and a couple of them were duplicates, for the same issue. So he was, really hurting himself more with the large number of prescriptions than one person not managing the whole thing.
right, that 20-minute conversation with your primary care to say, okay, doc, look, I'm taking all this stuff. Is there a better way? yeah, dude, stop eating French fries and drinking soda and having hamburgers and, maybe grill some fish and bake some chicken and eat some vegetables. Little things.
Anything that's not quite so painful.
you know, always looking for that quick fix, right? So that's really kind of the intro I want to do for this topic. When we come back in kind of our next episode, we're going to talk about lack of price limits. We're going to talk about hospitals and doctors getting paid for services and not outcomes, which I kind of alluded to in the last time. And I think we're going to talk about specialists getting paid much more based on their specialization, and whereas sometimes that's important. Like, I'm certainly more willing to pay a brain surgeon more than somebody else because if they're working on my brain, that's kind of a big deal. All right. But there also needs to be some equity in that as well. Yeah. So we'll focus on those three topics next, and we will see you again in just another week for our next episode of the Pulse of Healthcare.
Thank you, Dr. John. It's always entertaining and informational. Thank you.
All right. Have a good one.